Yesterday, when the conference was over and we had some beer outside, I was approached by a journalist, and she told me, well, I cannot attend your talk tomorrow morning. Can you send me your presentation? I'm very much interested in this question here. How do, oops, well, this is strange. How do psychotropic drugs work? And I told her, I can send you my presentation, but you won't get the answer. I just have questions, so I'm just presenting you questions. Is Thomas Metzinger here already? Thomas Metzinger, who gave a talk yesterday, a very inspiring talk, seems to have the answers. I just present you with questions. So usually when you go to a psychiatry meeting, and I think I will be the only one who shows you his disclosures. So these are my relationships to industry. So the dark side of the power. And people who work with industry usually are believed to get paid by the industry and to sell their products. Now, I'm working with industry more than ever. Right now, more than ever. I'm working with industry for almost 30 years now. And I'm showing you this because this is a kind of point where I come from. Industry is not only oriented or interested in making profits. They are also interested in developing products to improve patients' lives. I really believe in that, and that's the reason why I'm working with industry. But I'm very critical that some of the approaches they have are right, and that's what my talk will be about. Now, what I'm trying to accomplish in my professional career, what I have been trying for almost 30 years, is trying to cross this valley of death. Here we are the clinicians, and I'm a clinician. I have always been a clinician. I have been treating patients for for 30 years now. And here is the preclinical scientist. And especially in psychiatry, we have an explosion of preclinical knowledge, details about molecular neurobiology, neurochemistry, genetics, epigenetics, imaging. But very few of the knowledge that is gained here comes to the patient. So my talk is also about what's the reason for this gap. Why don't we understand, why don't we get the knowledge from preclinical work to the clinic, to the patient? We have begun to treat patients, psychiatric patients, not long ago, in the 19th century. Before that, patients with mental disorders were just locked off. They were not treated. So treatment for mental disorders just began in the second half of the 19th century. And this is one of the methods. Patients were put in these ice baths. And I will show you some more methods, like a malaria treatment of progressive paralysis. So this was a patient with progressive paralysis who got injected the malaria bacterium. And Wagner Jaurek, this guy here, got the Nobel Prize for this treatment. This is shock therapy of schizophrenia, introduced into the clinic in 1935. Electroconvulsive therapy was introduced by Italian psychiatrists a little later in 1938. So these were all shock treatments. We didn't know, and we still don't know how these treatments worked. They worked, but nobody knew at that time how they worked, and nobody knows today. We still do not know how these shock therapies, including ECT, electroconvulsive therapy, worked in the clinic. This is insulin coma therapy of schizophrenia in the late 40s and early 50s. And this finally is lobotomy in treatment-resistant psychiatric disorders. In various psychiatric disorders, this was performed. 1949. From today's perspective, this is a horrible treatment, and it's an expression of the therapists being desperate to do anything to treat those severely affected patients. Now, this was really a major breakthrough, the discovery of imipramine. Imipramine, the first antidepressant, developed or investigated by Roland Kuhn, a Swiss psychiatrist. And Roland Kuhn, this was really a revolution for psychiatry. He published in this paper in the American Journal of Psychiatry in 1958. So just 10 years after Freeman was performing lobotomy to patients, he published this paper here, The Treatment of Depressive States with G22-355, imipramine hydrochloride. Imipramine, the first antidepressant. And if you read this paper here, it shows very nicely that this was really a major investigation. And Roland Kuhn, 60 years ago, described in this paper also nicely a lot of things that we today know in psychiatric practice. For example, its mode of action remains for the present completely unknown. Completely unknown. It may indeed, in individuals who are predisposed, give rise to a somewhat manic-like condition or even a manic state. This is the switch to mania, which we investigate sometimes in the clinic when we treat patients with tricyclic antidepressants. So, Roland Kuhn already described this 60 years ago. And he also stated the mode of action is completely or almost completely unknown. Then Joe Schildkraut, an American psychiatrist, Harvard psychiatrist, he tried to understand the mode of action of imipramine, and he formulated the catecholamine hypothesis of depression. In this paper, just 7 years after the discovery of imipramine, he described the catecholamine hypothesis of affective disorders, a review of supporting evidence. And so the discovery of imipramine, its antidepressant effects, was a finding of serendipity, so a chance finding. And Schildkraut tried to investigate or describe the molecular action of imipramine, and from that, the biology of depression was hypothesized. And that's been shown here, in a very simple cartoon. This is the presynaptic neuron, the green is the postsynaptic neuron, this is the normal state. Here we have the neurotransmitter, this is postsynaptic receptors, and in the depressive state, the hypothesis states that there is reduced neurotransmitter serotonin or norepinephrine in the presynaptic neuron, and that there is less activation of postsynaptic receptors. And if we block this transporter here on the presynaptic neuron, we normalize serotonergic or noradrenergic neurotransmission, and thereby we improve depression. So the thinking, the hypothesis, was based on the mechanism of action, on the molecular basis of action of imipramine. And that influenced our whole thinking of the neurobiology of depression. So we had a drug which seemed to work against depression. We tried to understand its molecular mode of action, and from that we hypothesized the neurobiology of depression. And that was the basis for the introduction of SSRI into the clinic. The first one was fluoxetine in the late 80s. In 87 it was introduced into the American market. It came to Germany in 1989, and the New York psychiatrist Peter Kramer wrote this bestseller here. It came out I think in 91. That was about the time when I came to psychiatry, and there was a lot of enthusiasm that if we administer selective drugs to our patients, that we can change their behavior, their emotion, their mood, that we can improve psychosis, and that we can change mental health. And that was the basis also for everything what I did over the decades. And I'll show you just one piece of work I did over the last 30 years. That was a paper I'm really proud of. I apologize for my proudness. A paper written with Arvid Carlsson. Arvid Carlsson got the Nobel Prize for medicine and physiology in the year 2000 for his discovery of the role of dopamine in schizophrenia and Parkinson's disease, so in neuropsychiatric disorders. And what this slide illustrates is we have now very fancy methods like positron emission tomography. These are positron PET images of the action of 3 different antipsychotics in the human brain. So we can now study the actions of more or less selective psychotropic drugs in the human brain, in the living human brain. We can investigate their mode of action, and that's really fascinating. So we got a lot of insight into the molecular mechanism of action of these drugs. And I'm very convinced, although I will show you some critique of this approach, I'm very convinced that we are now doing much better with the treatment of our patients today in psychiatric practice. So treatment really improved, also based on such studies. We are really much better in patient care. But these are prescription rates for antidepressants in Germany between 2005 and 2017. And you see that the prescription rate more than doubled. And this is similar in all industrialized countries. In the United States, 12% of the adult population, adult means above age 12, 12% take an antidepressant. In Germany, with this number here of antidepressants, you can treat the whole population, 80 million, for 3 weeks, everybody. So we really have a problem. And this is also the expression of this chart here. This is incapacity days and incapacity cases per 100 insured years due to mental illness. And this is also very similar in all industrialized countries. Many people talk about a mental health crisis. So we have gained a lot of insight into the molecular mechanisms of action. We gained a lot of insight into the neurobiology of psychiatric disorders. But we still have a major problem in translating or in improving mental health of the population. If you go to any bookstore at a train station, this is just a collection, a small selection of journal articles, journal covers, showing that we really have a problem in mental health, generation burnout, body and soul, burnout, search for the self. How does the self remain powerful? Patient soul. So this really is an expression of a problem we probably have as societies. And this was on the cover page of the New York Times a year ago. Many people taking antidepressants discover they cannot quit. So 12% of the population take antidepressants, but usually many psychiatrists think, well, we have a defect. Depression is an expression of a molecular defect in your brain. So you take the medication, and then you have to take it forever, because that's the only way you heal the defect. Like diabetes, you have a lack of insulin, and if you make the diagnosis, you have to take insulin forever. And that's the concept that's behind the treatment approach in modern psychiatry. You have to administer the drug forever. But many patients don't like to take drugs forever, so they want to quit. The talk with the largest audience I ever had was a talk on quitting psychotropic drugs. Last year, when I gave a talk here in Berlin at our annual conference, there was an audience of more than 1,000 people attending a talk on how to stop taking psychotropic drugs. There are more problems. This is a study, and these are just single examples illustrating the problem we have with psychotropic drug treatment. This is a paper by John Crystal's group from Yale. So he's one of the leading figures in American psychiatry. These people studied, they took the clinical data from all duloxetine trials. Duloxetine is an antidepressant made by whatever. Insight into the antidepressant and placebo responses. So what they did, they calculated treatment trajectories, and they found that there are typical treatment trajectories. This is treatment with duloxetine, the active compound. This is treatment with placebo, and duloxetine is better than placebo, and that you can show with all the available antidepressants. There is a difference between placebo response and antidepressant response. And this is the illustration of those patients who get the drug, duloxetine, but don't respond. They are worse than placebo. So for this proportion of patients, this is about 1/4 of all patients treated with duloxetine, it would have been better to be treated with placebo. And so the hypothesis is that for certain patients, drug treatment with an antidepressant worsens the course of the depression, of the disease. And that treatment resistance for some patients is iatrogenic. We induce it by the treatment. That's a serious problem that we see many times in the clinic. Another problem is, again, we usually treat patients with those drugs for long periods of time, months, sometimes years. And again, the same group, the same Yale group here, they took the data of patients treated with 2 antidepressants who took the drug long-term, for prophylaxis of depressive relapse. Here at baseline, at time point 0, all these patients were in remission. And then half of them was left on the drug. They took the drug for another 6 months, 26 weeks, and the other half was put on placebo. And this is, and again, there are certain trajectories of Hamilton's, or trajectories of psychopathology, depressive psychopathology. Those patients who relapsed had the same trajectory with Verum, with antidepressant. This is antidepressant treatment, and this is placebo treatment. So those patients who were put on placebo had the same trajectory of depressive relapse over these 6 months. Here we had 46% relapses, and here we had 33%. 13% difference. So 1/3 of the patients who were treated with the antidepressant had a relapse despite treatment, 1/3. And with placebo, it was 46%, 13% difference. That's really a problem. There's really a huge unmet need for long-term treatment. We need better treatments. That's also the conclusion of these authors here, who are not anti-psychiatrists. Now, this paper has been shown in any previous talk yesterday. Gerhard Harris has shown that a single high dose of psilocybin seems to improve. I'm saying seems to improve because we really have to prove it in large double-blind studies. Seems to improve depression after a single dose. And this antidepressive effect seems to be long-lasting. 5 of these 12 patients are in remission after 3 months. So this is really a challenge to everything we have believed for the last 70 years. We thought that we have a molecular defect in our brains, we have to treat it forever with a psychotropic drug. And now these studies, these compounds challenge our views. You administer a drug like psilocybin or LSD, and you see an improvement for months. How can that be? This is not consistent with our view in psychiatric drug treatment. And this paper has also been shown yesterday. It's really a landmark study by Roland Griffith. The study which showed that, and it's a psychopharmacology journal, that's really interesting. The title, Substantial and Sustained Personal Meaning and Spiritual Significance in a Psychopharmacology Journal. That's really a revolution. And Griffith and colleagues showed that psilocybin induced an experience that many of the subjects here rated among the top 5 meaningful experiences. And that's really very interesting. So the psychiatric community now discusses the question, is this a pure biological effect? Can we explain this with pure biological terms? Or is it a matter of the experience? And how does experience relate to biology? So, I'm almost at the end. So for me as a psychiatrist, working with the conventional psychotropic drugs for almost 30 years, it's really a challenge to see these drugs working with a probably completely different mode of action. And it also challenges our view about the neurobiology of mental disorders. And I think this is a really challenging time. Well, this is my last slide, and then I'm at the end. This seems to be somewhat not related to my talk, but I will show you the challenge that clinical psychiatry now faces, someone like me. This was at the birthday symposium of this guy here, Gerd Laux, 70 years birthday symposium, at a very historic place. This is the Alois Alzheimer Saal at the LMU in Munich, where Alzheimer, in this room, he was his laboratory, Alois Alzheimer, 100 years ago. So this symposium took place in this very historical place. And these guys here, it's a pure, I'm sorry, it's a pure old man's thing. I think I decreased, I'm here, I decreased the mean age from 85 to 70 probably. Why am I showing this? At this symposium, these are the lecturers at this symposium. I gave a talk, a very critical talk, and after my talk, I got a lot of pressure. I showed some of the data I showed you here about treatment resistance and iatrogenic treatment resistance, about withdrawal symptoms and all that. I got a lot of pressure afterwards. And one of them told me, we had a nice dinner in the evening, and one of these guys, I don't tell you who it was, came to me at the dinner after the 10th glass of wine and told me, you have to be very careful. You cannot say this in public, especially not in such an audience, because you kick yourself out of the field. So this is a challenge academic psychiatry faces. We have to ask critical questions and still remain scientific. And that's really the challenge, and that's why I find this conference so challenging and so inspiring and exciting. So this is exciting times for psychiatry and for myself. Thank you. Klar.
Thank you very much, Gerd, for this very insightful talk. We would like to take 2 questions from the audience.
Hi. I have a critical question to ask you. I was heavy metal poisoned in my early life by rocket testing, which I just discovered, which was the cause of 45 years of treatment-resistant depression, suicidal depression. Once I got the heavy metal out of me, my depression ceased. I was able to get off medication. Mm-hmm. Why doesn't psychiatry automatically test people for heavy metals? They just send them straight to the drugs.
Well, because there is no indication that in certain cases heavy metals might be the cause for depression, but in most cases it's not. So since we don't have a single cause for depression, we have to watch carefully and investigate, of course, somatic bases of depression in every single case. But there is no single answer. So heavy metals is not the answer to depression. I'm
Seems
certain.
like it would be good to rule it out in the beginning. Would have saved me.
Yeah,
a
yes.
lot of-
If you have, if there is an indication that you were exposed to heavy metals for a long time, then of course every serious psychiatrist should do that. Of course.
Everybody who has mercury in their mouth is exposed to heavy metals.
That's a different story.
Yeah, anyway, thank you for the answer.
And another question? Anybody?
Well, first, thanks for your talk, as well as thanks for your insight and, let's say, humble and realistic of how the situation is. So you make it really clear that the data is here, the problem is here, and the possible solution is here. But the last picture was really clear. It cannot be changed from within as it is. You need to really change, it cannot be an old white man still. So what can people from outside, the non-psychiatrists, entrepreneurs, can make to change you guys and to make the change?
Oh, I think we don't have the time to answer this question.
Let's start with the beer.
I think the whole meeting is about this question. I have no simple answer. There are different ways to approach this, and that's why we are here, and that's why we are interacting, the Mind Foundation and academic psychiatry, and many different psychedelic associations working and interacting with academic psychiatry. That's one path. Okay?
Thank you very much, Gerd.